we got a few people signed in, so let's get started. My name's Paul Haber. I think you know of me from previous exciting opportunities like this, and this is the monthly OTAC webinar for prescribers of opiate treatment and others who are interested. We're funded by New South Wales Health through the OTAC program. And I want to start by acknowledging the traditional owners of the lands upon which we meet. I'm in Gadigal land of the Eora Nation, and I know some of you are from all sorts of other places, and I want to pay my respects to Aboriginal elders past, present, emerging, and particularly to any Aboriginal people who might be taking part in this evening. I hope there are at least some. I also want to thank Daniel for his great assistance with this evening, and in particular, helping me to knock my slides into at least some semblance of shape. And also, he's going to take us through this new software thing.
Yes.
Daniel, do you want to explain that?
Yes.
Or does it
no,
not
happy
need
to.
explaining?
No, I'll briefly explain it. I feel like I'm getting a bit of feedback. Is anyone else getting that on there?
Yeah.
Yep. Just going to double check. No, I think that's all resolved now. I can't seem to hear it anymore. Just going forward, just as a reminder, so as Paul sort of did indicate, we are wanting to trial sort of this new little software to enable interactivity with these webinars, and we'd love your feedback on it. I will first just very briefly show you who is registered for tonight, as always, to give you a rough indication of people who we may be expecting online this evening. Once again, it's fantastic to see some regional representation, as always. And we do have a few people from interstate, particularly in the ACT, so welcome to those from interstate as well if you are joining us. We have 18 people from the Southeastern Sydney LHD sort of basin area as well, which is quite high compared to the other Sydney-based areas, so good job to you guys. Just a very quick reminder, so as always with these webinars, we're trying to provide a learning environment for OAT prescribers and other health professionals in this field to have open discussion about specific topics related to OTP. They run roughly monthly, though, as you may be aware, we didn't run one over Easter last month. So expect more in the coming months as we go ahead. And as always, we do record these webinars, provide slides and resources at the end of the day, which are available on the OTAC website as well. And we're always looking for suggested clinical topics or cases, so feel free to email me if you have any questions about that or want to provide one. Just, of course, please put yourself on mute if you're speaking, unless you're speaking or asking a question to us. Do encourage you to put your video on, particularly if you are asking a question. And also use things like the raise your hand function and things like that. Other than that, we do, of course, ask you to be polite and considerate, though we're very open to having robust discussions. And please let us know if you think you have a conflict of interest related to this topic, but you haven't had that as of yet. So as I sort of mentioned, we are going to be using this system tonight called Menti to sort of facilitate discussions and answering quizzes and things like that. What it would require you guys to do actually is to either open up the browser on your computer and entering in that short URL along with that code, or you can do that on your mobile phone if you like, as well as scanning the QR code. So we really just want to trial this and see if it works well and get your feedback. And there'll be certain pages where it'll prompt you to answer questions, and then at the end, it'll basically show responses and things like that. So it can range from yes or no questions to sort of providing text responses, which will show up as anonymous questions, as well as sort of cloud images and things like that. Hopefully you'll see what it looks like when we get to it. But other than that, I will hand it over to Paul.
Okay, so I hope some of you have clicked on that link. Was it shown for long enough? Yes, somebody's no.
It will also show up on future slides as well if anyone didn't get to it. But if you get the chance, feel free to scan that QR code now.
Okay.
Wonderful.
So next slide. We're just going to talk about some common clinical challenges in OAT tonight. It's not going to be a very highbrow session. Hopefully it's a practical and useful opportunity, both for me to raise a couple of points that I thought would be of interest and for participants to have their say as well. I'm going to keep the chat button open so anyone can use the chat button in the Zoom app as well as in the Menti app, whichever you're comfortable with. So we're going to talk about a patient in prison, some issues with medical records, something about routine care, and something about urine drug testing. And can we go to the first case, please? So first case is a chap who's in prison, a 39-year-old, and I might add that the largest place providing opiate treatment in New South Wales is actually the prison system. So it's far from an obscure topic. A 39-year-old patient is in prison, attended your clinic, and he's requested access to join the OAT while in custody. Access is limited. It's hard to get an appointment, but this guy's got one. He reports a history of opiate dependence, a long-standing history, and he was on the methadone program and buprenorphine program for a number of times for periods of 6 to 12 months over the past 10 years. He states, however, that he's not used any drugs in the past 6 months, but he's feeling like maybe he should be on the program. A nurse reports that he was found with the Suboxone film in custody. The patient says he bought it for a friend. It wasn't for his own use. There's no evidence of any drug use that would counter his claim that he's had no drugs for 6 months. So I guess my questions for you would be to ask, firstly, would you say he still has opiate dependence? I'd be interested in what people think about that.
So at this stage, anyone, you can feel free to unmute yourself to discuss this, but otherwise everyone can go to that short URL at the top and you can start inputting whether or not, what your answer would be for that question.
Does that mean that 1.5 people have said he's got opiate dependence?
No, so it sort of evens out, and I've just hidden the results because I just realized I forgot to do that, just to so that everyone can provide some input without being overtly concerned about other people's responses.
Wow, there's a line. Is someone drawing on the screen? I've got someone
drawing on the screen. I think that's a Zoom function, actually.
Okay.
Yep.
Well, I don't mind if they're drawing on the screen.
Yep.
So let's, why don't we unhide the results or show the results and proceed on.
Yep. So we've had about 14 people respond so far, and it's sort of going up as we speak.
So what does 1.5 mean?
So that's sort of indicating the proportion of people that have indicated yes or no.
We can't have, can you make it like just numbers?
That is a good question. No, that doesn't help.
Wow.
So I think it's showing the trend results. I've had one person saying that they can't figure out how to respond to it.
So Dan, excuse me, these are 3 different questions, and they're not three options of one question. I'm wondering if
No. Yeah.
Does anyone want to? 1.6 people think it's going to change if he was in a community.
I'd hazard to say that it's the average score, because the scores are 0, 1, or 2, and I think it's the average of the responses that have come in.
So when you say it's 0, 1, or 2, 0 would be no, 1 it would be yes. What's 2?
I know. I think it's so 0 or 1 in this case.
0
Sorry,
1.
1 or 2 in this case. But as you can see, for the first question, we've had 9 people say yes, 11 people say no. Yeah.
Oh, okay. Now I have an answer that I can understand.
Yep, there we are. Got there in the end.
Okay. Right. And for the so let's discuss that. This is actually not a rare scenario in prison, because access to drugs is absolutely lower than it is in the community, although many of our patients tell us that they have no problem accessing drugs. So even those that use drugs are almost certainly not using daily and are using it less. I think the point I think that I wanted to make here is that it's not black and white. I haven't given you a very lengthy, detailed history and a clinical assessment beyond saying that I don't think he's currently using drugs. And in that situation, the key point I want to make really is that he may well still be opiate dependent, is the key point. And therefore, if he's come to a clinic and requested access to the opiate treatment program, it's highly likely that he's still at high risk of recurrent opiate use. So I think whilst one can make further detailed assessments, one can look at urine drug testing, detailed clinical history. I think if a person with long-standing opiate dependence who's been on and off the program for 10 years requests going back on the program, in all likelihood, there is continuing craving for drugs, desire to use drugs, and he's probably telling us a little fib about that Suboxone script, sure. That's Suboxone film that he was found with, surely. Now, I'm just looking at the chat here. We've got some chat here. Nicole says she's really glad we're discussing this case. You have a similar patient. Okay, so I'll tell you the truth about this patient, and that will colour your answers. But the truth about this patient is that this fellow died of a drug overdose, and I was giving evidence to the coroner's court not all that long ago about the case. And as I think anyone working in Justice Health or in or around Justice Health knows, the period after being released from jail is a very high risk period for opiate use, opiate overdose, and overdose-related death. And the sad case on my mind was just a classic and distressing example of exactly that phenomenon. He's a youngish sort of fellow. And a strong focus of our clinical inquiry was, should this chap have been offered opiate agonist treatment? And as I think most of you would know, Justice Health absolutely has offered pre-release and opiate treatment, and particularly now with the Depot Buvidal long-acting product, is very keen for people at any sort of risk of opiate dependence to have at least one shot before they leave the jail, so they are, inverted commas, covered for that early period and are linked into one of the community treatment programs for continuing treatment in the high likelihood that that would be also clinically indicated. So I mean, that's my secret hidden agenda. It's pretty unusual for a guy to go to an opiate dependence treatment clinic, have an appointment and say, yeah, well, I'm in the wrong place. You know, I should have gone to the dentist or something. If a guy's gone into an opiate dependence clinic and wants to have opiate dependence treatment, really, you've got to come up with I think the onus is on the clinician to come up with a reason not to do what he says. You've got to be fairly convinced that this guy's not using, he's not at risk of using, he's not going to be at risk of using. And the answer is usually quite clear, really. Now, I'm going to now read, here's what Lucinda Scopelliti said, excuse me. Well, Linda's response is spot on. He's likely at risk of relapse and overdose, so if he's asking for treatment, fair to assess and offer, even if he's not currently opiate tolerant. So clearly he's not opiate tolerant now. Good point. If he was to go onto methadone, you'd want him on a very low dose, very cautious dose increases, avoid high doses of methadone. Most new patients onto the program are not going to go into methadone. They're going to go into buprenorphine, where tolerance is less of a critical issue. Wendy Munro makes a good point about stabilization. Nicole says, everyone gets offered OST prior to discharge. I suspect that most patients do, but in the jail, nothing that we think happens to everyone actually happens to everyone. Wendy completes. Oh, cost involved in custody recommended. Well, it's not the large. Would Wendy like to go off mute and just say what she was thinking there?
Yeah, thanks, Paul. Look, we have clients coming to us that may not use opioids in the community. When they go into custody, they are using opioids, and it may be the costs of the opioids in custody are huge. So then they're not using a lot because of the cost, but enough to have a dependence by the time they're discharged. So their transition, as you mentioned, their transition then into the community, they have enough of a dependence to be able to use illicits, and their risks then are high for overdose.
Yeah, thank you. Really, the key thing I just wanted to make, and there, you can discuss the ins and outs of opiate treatment in the jail. It's a whole topic for another day. But really, the key point I wanted to make with this case is just a simple point. If he is not currently using a lot of opiates, he still can be opiate dependent. He clearly won't be tolerant, and he still could be appropriately treated with opiate agonist in an appropriate dose to reduce his risk of opiate-related harms, either in jail, as Wendy was just explaining, or after release. That's really the point I wanted to make. So should he be offered OAT? My answer is yes, if he wants it in this context. Point 3, would my answer change if he was in a community clinic? And I think we are, now that I understand how to interpret the numbers on the screen, it says that we're slightly split 50-50 on that, slightly more saying no than yes. I think my answer would not change in a theoretical sense, but I think the clinical assessment and the practical issues, the risks involved, they would all be different, and you would need a proper assessment of what's going on to make a decision. But I guess what I was thinking when I asked this question in these words is the answer would not change, that a person who is not using opiates currently might still be opiate dependent and might still merit treatment with opiate agonist is what I was saying. But of course, if the circumstances change, sure, the answer of their correct treatment might change with it. Let us move on. Yes, so he was declined treatment. He was offered an appointment should he feel the need to represent. He never returned. I mean, what are the chances of someone returning in that situation, in the chaos and drama of a difficult clinical setting? There's not a privately insured patient being asked to return to his favourite GP or something. A patient was released from jail and he was found deceased from an overdose 10 days later. He's not the first and he won't be the last. Why did this occur? What could have been done differently? And what issues are present in this case? Honestly, I think we've discussed those things. Does anyone wish to make any comment? Michael Levy says my question's ambiguous. Michael, you may be right. The patient has been released. He may have left prison before being initiated on OAT. That is absolutely a possibility in the chaos and drama of it all, which is why I think it's incredibly important to, in a case like this, make a decision and implement the decision and not procrastinate too much in a scenario where the patient and the clinician may never meet again. Very unclear, says Dan, if treating him with opiate treatment would have kept him alive. So I would. Does anyone want to comment on that? Nobody? Well, there's no doubt that there's evidence that use of opiate agonists does reduce opiate-related death and does so in the post-release setting, but it doesn't reduce it from 100% to 0%. It's got a certain percentage reduction. So there is absolutely never going to be a guarantee. It's not very clear. Lucinda Scopiletti is answering all the questions so beautifully. Very clear that opiate treatment does reduce overdose death. Exactly. It's not going to guarantee, but it. So yes, it would. And by the by, the coronial post-mortem toxicology showed massive doses of opiates. So he died of an opiate overdose. He had other drugs as well, unsurprisingly, as most of them do. Depot would have been very effective, says Wendy, in reducing risk post-discharge. Thank you. High risk time, indeed, says Angela. So clearly, individual cases vary, and the entire management of the pre-release and the post-release scenario is something for which we don't have a straightforward answer how to maintain treatment and connect them in treatment effectively. Those of you who are involved will be familiar that Adrian Dunlop is leading a TRGS, New South Wales Health funded project called the Release Study, which is looking at exactly this question of what are the rates of continuing with treatment after release from jail, what are the predictors, what are the processes that we can use to achieve more successful transitive care. So and that trial is about halfway along the way. Was he offered take-home naloxone? Yeah, I'm pretty sure he was. I'm pretty sure he declined it or lost it or didn't have it with him at the one moment in time when it was critical, and he injected and died alone. So if you inject alone, it's going to be very hard to find somebody to administer the naloxone. So again, it's a great intervention to have available. I'm a big supporter of it. Like I think certainly Joe Lung, who asked the question, I'm sure is as well. It doesn't work in every case all the time. Okay, let's move along. I think we should move to case 2. Now you're a GP and you're in a or a nurse practitioner or whatever you are. You're in your community clinical practice, and today you're seeing a patient who's on opioid agonist treatment who's been treated in your practice for the past 3 years, but he's usually seeing another doctor. That doctor is unexpectedly unavailable. The patient lands on your doorstep and their prescription is due for a renewal. You're flicking through the notes, electronic or paper, whatever they are. And when you see the patient, you look through the notes and you find very little information about the opiate treatment program. So what documentation and information would you expect to be included in the patient records that would make you confident that you can write a script for, let's call it 80 milligrams of methadone, and not get into trouble and be providing safe care? Who wrote that? Someone said diagnosis. Dan, did you write that?
No, I didn't. So someone has provided that.
Okay.
So if you guys want to go to that link again, or if you've kept it open, for those that have just joined us late as well, you can either scan this QR code or go to that URL and enter in that code. And basically there are text fields and you can start typing in your thoughts about this and it'll start popping up on the screen. So we'll give her a
you're allowed multiple entries, but you don't have to have 10 entries. You can just write one word like this very clever person did. And to be honest with you, there we go. Yeah, so the reason we're presenting this particular case is that I've been doing a couple of medico-legals of a patient who is suing their doctors for doing something wrong. The patient survived, but as I was flicking through 5 years or 10 years or whatever it was of medical records, I swear I could not find anyone who'd written down a diagnosis of opiate use disorder or opiate dependence anywhere in the notes. So a clinical assessment that provides a diagnosis is absolutely essential somewhere in the notes, right? Somebody says, check the authority. So I tell you what I do, because when I work in a hospital, I'm being asked to write a script for patients all the time. So the first thing I want to do is I look at the last script. And I want to see that, I check the ID of the patient. I want to check that the script. I want to see the dose, and I want to see when does it expire. Because, if it expires in 3 weeks and the other doctor's going to be back tomorrow morning, then I'm not going to do anything. I'm going to say, don't panic, don't worry. Your doctor's going to be here in time. I'm going to think about what is the treatment plan someone's written. I'm going to think about progress notes. So I guess the key thing I want to say is when I look at the notes, I'd like to see some of the stuff that's on the screen now. It'd be nice if I could see it all, but you'd be surprised how often you don't see any of that. What you see in the notes is, patient getting on with his wife better now, or he's lost his job, or he's thinking of going away next week. You see some social stuff, always relevant to understanding the patient you're with, but what you don't see is what's written on the screen, because all of the comments on the screen, and may I suggest we stop adding comments to the screen now, because it keeps doing that. It keeps buzzing around. I think can we finalize it there?
Yeah.
I think, because I think what's written on the screen is beautiful. It's all the key things. We can check the script, we can check the diagnosis, we can check his recent progress. We're interested in recent substance use. We're interested in the safe script update. We don't have to do that every time we see a patient, but perhaps in a new patient. we're interested in the situation about takeaways. Is it safe to give takeaways? Is he getting them? So, but if this is just a takeover, this is just a one-off. Wendy's loving SafeScript. I'm loving Wendy. Very good comment. I'm loving Scape. Having railed against SafeScript for about 2 years, I now find it indispensable. And there was an email today, Wendy, I don't know if you saw it, an email that SafeScript is going down over the weekend as they're doing some upgrade to it. And I thought, what a change it has been from nobody giving a toss about that to now, if it's down for the weekend, we're all fretting. But it's only the weekend, it'll be fine. So I think SafeScript is absolutely essential to keep track of what's going on with our patients. And whilst you have to be a little bit pragmatic if you're just taking over a patient for a little while, if you're managing a patient long term, you've got to make sure that everything that's on the screen now is in your notes. Not every time you see the patient, but at some point, so that people can flick through your notes, so that you can flick through your notes, and frankly, so that when the lawyers flick through your notes, they find very little. And if I may say, one of the other things that was incredibly absent from the notes was when a patient declined treatment. So a patient on lots of OxyContin, as an example, your doctor is you as a doctor, you're recommending, you're diagnosing he's got opiate use disorder, you're recommending he has opiate agonist treatment, but somehow you keep writing scripts for OxyContin. So the reason is, of course, that the patient has refused. And you've said, I'd like you to go to an addiction clinic, or if you're a prescriber, I'd like to prescribe you opiate agonist treatment, and the patient has steadfastly refused. But you'd be surprised, the cases that I've seen, notes don't say that. So what the notes say is, doctor says, you're taking too many OxyContin tablets, and there's a script for OxyContin. That's what the notes say. That doesn't say to me that the doctor has either recognised the problem, has recommended a safe and effective course of action, but is hamstrung by being unable to engage the patient in the process. So I think it's also important to say what you're not doing if there's a strong reason. You know, I recommend detox, patient doesn't want to go, declines, can't leave work, whatever the story, got to say the story. So I think the quality of our medical records is important. Okay, let's move on. Scenario 3, routine clinical appointments. 30-year-old female patient is on methadone for 3 years. The patient's been doing well on treatment, currently getting takeaways, weekly takeaways. Patient drives an hour each way to town for their clinical appointments and to collect the takeaways. Presents for a routine prescription renewal. During this consult, what should you consider doing in your review of this patient? Someone says, what dose? 80 milligrams. Why do you ask, Wendy?
Look, I'd just look at the safety of their driving that length of time, but I'd also be interested in other substances used as well for that trip. That puts them at risk to the community on the roads, and would be a
other
concern.
Substances, dose other substances. So during this consult, those are good things to keep in mind for sure. What else would the audience think should be considered in the review of the patient? Would you like to type in a couple of other ideas? And anyone who wants to just blurt out their thoughts, you're welcome. 2 people want to do a UDS.
Popular answer.
3. Do we have answers here, or do I just sort of? I'm just
no,
trying to remember.
it's just showing what's It's just showing what people have provided as an answer to this question. Yeah.
Yeah. So, yeah. So, oh, I know. Oh, that's case 3. Yeah. Okay. Yep. So, extraordinarily, no one's asked if she's pregnant. They've asked if she's on contraception. Meant to be medical history, not host. What was that? Yeah. Everything relevant to general practice care. Yeah. On the one hand, that's true, but everything relevant to general practice care takes you 45 minutes. You're going to take 45 minutes with this lady for a routine review? You're not. You've got 10 to 15, haven't you? So what are you going to do, having filled the screen with options, right? What are you actually going to do in your 10 or 15 minutes for this this woman? And I might add, it's not immediately obvious that there's any problem here. There might not be a problem. So just to be practical, you can ask for a urine drug screen. I would look in the notes and look at, when was my last urine drug screen? How often do you do them? Can I ask Michael Levy to just say, how often would you do a urine drug screen in I think I said she's a 30-year-old woman?
Yes, correct.
I said she's 30. She's been on methadone for 3 years. You're going to do the occasional urine drug screen. If Michael's still here, can you give us a number? How many times a year are you going to do a urine drug screen? Michael's not here. Who would like to make a comment about the number of times a year they're going to do a urine drug screen? I don't know all of you. Michael is here. He's on mute. Ask to unmute.
Okay, I'm on unmute.
Right. Thank you, Michael. I'm just picking on you. I'm picking on you because I like you.
Thank you.
How many? So this is a 30-year-old woman. It's absolutely routine case. She's on methadone for 3 years. There's no screaming at you that there's a problem. The only thing that's slightly outside the bog standard case is that she's getting a lot of takeaways, and she's driving an hour each way. She's driving a fair bit, more than the average. How many times are you're going to do the occasional urine drug screen? How many times in a year? I'm not asking what you actually do. I'm asking what you think you should do. Four. Someone's written down the number 4. Thank you. I don't know who it was. And how many do we really do? So,
Lucinda.
Who?
Lucinda again.
Lucinda says, why do you say 4, Lucinda?
I think it's random, plus or minus 4. I'd be checking for any injecting marks every now and then as well, just to see what's going on with the takeaways.
Someone says, you see, there isn't a black and white answer.
No.
We've got answers. I mean, we literally have answers from I rarely do them to 12. If someone says at least once a year, 2 to 4 times a year. Okay, so I'm going to just be honest and confess. I flicked through the notes of some of my patients and I can't find the last urine drug screen. And it might be 2 or 3 years. And I'm sure that's not right. I'm sure it should be more than that. So I think the the risk and the trick is when the patient kind of looks okay. Because if the patient's unstable, they look intoxicated all the time, you think, oh, gee, this person is using lots of drugs. I think clinically the urine drug screen is less important and less useful. This is the, like in Sherlock Holmes, the dog that did not bark in the night. This is the patient who seems to be okay, but she's getting a lot of takeaways. And so I think this is a lady who does need to have at least a couple of urine drug screens. So we have a bit of a picture that validates our clinical assessment. Look for venipuncture marks, just be a little bit incisive in your clinical assessment and aware that the patient may seem like a really nice person and everything, but on the other hand, she might be very unstable. And the first time you find out there's a problem is when she smashes her car into a bus or something like that. And I think that the takeaways in the driving are clues that we have an obligation to be a little bit more cautious in what's going on, and we should scrutinize the history, the physical examination a little bit carefully, particularly if we're in a regional scenario where we're not seeing the patient very often. There's not much scrutiny at all. So when you do see the patient, I think we should be incisive. Okay. Any more comment? Anyone want to comment on that? And by the comment about depo-buprenorphine is a very good comment. But this lady's on methadone, and quite possibly she's frightened of the changeover and does not want to change. And that's a topic for another day. It would be good if she did, but she may not wish to. Let's move on and go to our last patient. Another urine drug screen. 48-year-old male patient's been receiving Suboxone for 6 months. He's been on and off opioid agonist treatment 4 times since the age of 25. Medical records indicate he frequently has used drugs whilst on treatment. And the urine test from the last month was done, shows a positive for benzodiazepines. My question is, how often do you think this patient should receive a urine drug screen? And how do you discuss it with him? And what actions are you going to take about this drug screen? Is there someone who hasn't spoken who would like to say something? Linda Doherty. I'm just going to look here. John Smart. I know John. John, how do you feel about me asking you to make a couple of comments about this scenario?
Look, I put a comment on the chat.
Okay.
It really depends on the setting and the patient. And now you've known me working in clinics and in the inner city. I'm now in primary care, and I see patients that I've known for a long time all over the state, mostly by telehealth now. And the problems I encounter are that many private pathology centres refuse to collect urinary drug screens, and it can be, and there's the issue of getting a request to the patient, which we can do sometimes by e-health pathology requests, but they often get lost. And then we've got to be able to nominate the service provider. So post-COVID, with the changes that occurred, I went from being pretty rigid about urinary drug screens to really quite remiss, and I sometimes think it's almost negligent, but it's really a function of the circumstances that I'm in. So far, I haven't had any misadventures.
Yes.
So, you know, it's difficult. It's particularly difficult with the way that telehealth is evolving in OST. You know, different to working in a clinic.
Yeah, so I don't know, does anyone else work a lot in telehealth, and does that influence whether you're going to need more or less urine drug screens? Well,
it just makes it harder if you've got a patient in Newcastle that you've known since you met them in the inner city 25 years ago.
Yes.
How do you get, and they're living in the Upper Hunter.
Yes.
How do you get them to do a urinary drug screen, or even to get their, post hepatitis C bloods? It's if they're a high risk patient, then you can really make them get in the car and come to see you, even across the city. But a lot of the times, the patients are often working in the kind of strata of patients that I'm seeing now. So things are really different in different places.
Yeah, but I think, there's two reasons to do stuff in medicine. One is to improve their health so you can get things right, and the other is to defend yourself in the event of something going wrong.
Yep.
And if everything's fine, well, frankly, it doesn't matter what you do, really, does it? But if things go pear-shaped, how will we defend ourselves if we haven't seen the patient face to face? We have no laboratory data. We have no collateral from a pharmacist or a clinic nurse or their other GP. So we're flying solo and we're flying blind. And I think our defensive position would be weak. So I think if you have very limited contact,
10-year relationship with the patient, that it's hard to see that as a person who's reviewing the notes. But the
10-year relationship
over time.
Yeah, I think it's fair to say that a 10-year relationship may give us deep insight. It may also have allowed for a folie à deux where they fool us and we fool them, and we're barking up the wrong tree, and we get some big surprises. I've had patients that I've had a long relationship with who I got it totally wrong, and I'm not the only one. So I think if you have less face-to-face encounter, I think a UDS might be a good idea. Someone says a UDS every 6 weeks. So that's 10 a year, or nearly 9 a year. I think that's unlikely to help the patient. And I think one has to remember that a urine drug screen is in fact an unpleasant and punitive, potentially punitive process. And so I think one has to be I can't imagine a situation where a urine drug screen every 6 weeks would be a good idea. None of my patients would do it, to be honest. They wouldn't be my patient after 2 or 3 goes around that particular one. And someone's also raised the question about, is this person suitable for opiate agonist treatment if they are using benzodiazepines as well? So in some highly structured and potentially rather punitive programs, particularly in the States, if they were using benzodiazepines, if they were using opiates on top of prescribed opiates, that was considered a violation of the protocol or the program rules, and they were either disciplined, warned, or even discharged from programs. So that's good for the program because they don't have to worry about any complicated patients, and they don't have to worry about any of their patients getting into trouble. But they will be discharging a lot of patients who will then be in a lot of trouble, having adverse events, overdoses, deaths, and dumping all the challenging patients on someone else. I have to tell you that about a third to a half of patients on opiate treatment programs are using benzodiazepines, at least intermittently. So it would be rather difficult to maintain much of a methadone program if you didn't allow, or if you discharged every patient that was using benzodiazepines. So I think that's not a practical long-term approach. Good for eyes of new prescriber. What's this? Occasionally, Paul, for that reason. Angela, I don't understand what you just said. Could you explain that? Come off mute and just say it. Do you mind if I ask that?
Hello, is that working? Ooh.
Well, you sound like you're coming from another world.
No, I was just saying about your folie à deux thing.
Ah.
You know, sometimes
okay.
I have a colleague to review our patients. Sorry, it's going.
Okay, so you've got two speakers on in your wherever you are. So what you've just said is, I think what you're saying is it's good to have a second set of eyes on a patient from time to time. And I think that's a tremendous idea. I think that's very important. I don't know if I'm allowed to tell you the story of my daughter having her baby in London just 3 months ago, but she did. And in the labour ward in that hospital, every hour on the hour, a second midwife would come in and just do a basic check of all the things. And then if everything was fine, that second midwife would just say, everything's fine, carry on, and leave the my daughter in the care of the primary midwife. And that second set of eyes was introduced in that hospital so that people would stick to the protocol, and that this relationship between, you know, the midwife and the mother, they wouldn't just get stuck in doing whatever it was they were doing, that someone would come in and make sure that everything, the whole protocol was followed properly. And I think that same analogy can be applied here, that I hate to say it, but sometimes we wind up our conversations with the patient from month to month, or however we see them, tend to run to a certain pattern. We talk about the same things. We don't necessarily systematically go through everything we're supposed to do. And I think a second set of eyes is a very neat idea. So I love that suggestion. And of course, it's not a practical suggestion for a solo practitioner in a remote location, but it is a practical situation for many of us in many other types of situations. Dan Ewald says he would expect the UDS to be less punitive if it is set up as normal practice at the start of treatment. So normalise it. And I think that's a good comment. I think even though we normalise it, it's like saying blood tests. We're going to do some blood tests on patients, and it doesn't have to be punitive, but it's still an unpleasant process for patients, and they don't want to have too many. Do we have to have witnessed or unwitnessed urine collections? Any comments in the chat or in the unwitnessed, says Nadir Molavi. So okay, mostly unwitnessed, and that making it witnessed makes it much harder. And so sometimes the local pathologist that refuses to do it is concerned about forensic chain of custody issues, and in particular the Australian standard 4308, I think it is, but the Australian standard for a evidentiary urine drug screen requires that the urine collection is witnessed, that the temperature of the urine is checked and recorded, and that the pH is checked and the creatinine is measured. So all of that's very neat if you are in a legal situation, but here we're collecting for a different reason. and an unwitnessed urine is what we are looking for. And so we are not following Australian Standard 4308. So unwitnessed, yes, please. Copy of the client to discuss with the option to discuss for a GP for an independent review. Community pharmacists can be the second set of eyes, and you'll need to use your set of ears to communicate with that pharmacist. You'll have to ring them up every now and again. I've found ringing up pharmacists is quite a pleasant exercise. We go in, we don't have to see them, we just have to go in and check it's warm. Well, you know, you can do that. Chain of command, chain of custody is what we mean for urine collections. I think the other issue that I just wanted to bring is that if the urine is positive for benzodiazepines, it's certainly, oh yeah, all the other issues to consider have been typed onto the screen. Open discussion with the client about benzo use. What is the indication? What is the source? How many? For how long? Is there a safety risk? Driving, childcare. Someone's written, that's a fabulous answer from whoever. Give yourself a pat on the back. And the other comments are also very, very appropriate comments. Is there sign of, what's their mental state? Is there sign of intoxication with these benzodiazepines? Is it something to the extent that you are concerned about the safety of prescribing the same opiates as before? Potentially you feel that the patient is so intoxicated it's unsafe and you're going to reduce their dose, or advise them strongly to stop using the benzodiazepines. Because of course, agonists, opiate agonists, particularly methadone, when combined with benzodiazepines, increased risk of overdose, increased risk of toxicity generally, and therefore, yeah, I'm just reading the comment on the right of the screen here. Overdose risk education and benzodiazepines, urine drug screen at every review. Okay, the first sentence I think is very good. Second sentence, it's not really practical to do that. But if they are positive for benzos, then it may be good to do a few more urines to say you'd like to see some of these urines being negative for benzodiazepines for the reasons that we've just discussed and are on the slide. I think that brings us about to the end of our time, to the end of the cases. Does anyone have any final comments? Janelle Hall has a little story there about urine that I have to tell you. You have to read it. Have to read it before we go. You really do.
Would you like me to tell you the story?
Yeah, I would.
Okay, so lovely young gentleman. Whenever you met him, he's very pleasant, well-dressed, always incredibly kind. Just happens to use a little bit of heroin, a little bit of cocaine. So static. Anyway, he knew that we were wary of him, and so we always do random urine screening for our patients. He actually used to freeze urine when he was clean, so it only had the methadone in it, so that he could at any point in time be able to produce a sound, normal urine sample. And so I said to him, so seriously, you would put an ice cube of urine into your pants to let it melt? Because yeah, it had to, so it was at body temperature, so I wouldn't get told that it was wrong.
Well,
yeah.
So I think the more punitive, one of the things about patient disclosure is that the more they are punished for saying something or doing something or showing something in their urine that we don't want to see, the more they are punished for that, the more they are given an incentive to avoid punishment and, not tell us this stuff. So if we don't punish them for having something in the urine that is not ideal, then they're not going to play these silly games. It's just simply not going to be worth it to them. But if, to the contrary, the patient had a firm belief that you would discharge them from the program if there was evidence of heroin, then, you know, I mean, this is pretty aberrant behavior, but you're not quite so surprised that they feel that way. So I guess the less punitive our approach will be, the more likely the patient will be to behave sensibly. Or another way of saying it is, if you treat them like adults and responsible people, they might behave that way. And if you treat them like criminals, they might behave like criminals, and so might we. So I think we're going to stop there. We had some notes about language, and I'd like to defer that for another time, because we're out of time and we've talked about enough. I think we've done enough for today. And okay, Janelle's giving us more detail. And there's just some supports that Dan has put up on the screen that I hope you already know about. And I want to thank all of you for participating. We've got upcoming topics. We've got this seminar every month. We've got our next one is on the 20th of June, and we are going to do a bit of a deep dive into Safe Script New South Wales, which is being upgraded this weekend. And we're going to have topics later in the year on more details about custodial settings and post-release, chronic pain management, mental health management, and other topics. And we absolutely do welcome clinical questions, patient cases that you would like to discuss, or you would like us to discuss, by email to Dan. You can email it to me, but Dan reads his emails, so please send them to Dan. And I'll close the session now, and thank you all for your time and for your active participation. It was really pretty cool. See you all.